So I'm Josh, and I am a family doctor. What I really like to spend most of my time on is trying to convince my patients to change their behavior. So I like the challenge. I have no declaration of interests. I don't get paid to talk about exercise. I do get a small stipend for this talk. However, I'm pretty active in a lot of sports still, and even coach a little bit, and that probably colors my perspective a little bit. So actually, this talk was actually initiated by Aaron, the topic, because I just thought, well, nobody really needs to hear more about exercise, but I do wonder, what if we compared exercise to drugs for a lot of the things we see in primary care? So that was sort of something I was curious about. So here we go. So I found 4 studies with the help of the folks at the TI that looked at 4 different outcomes that I think are interesting: visceral adiposity, hypertension, depression, and early death. I'm going to take a brief look at these studies and look at the results. But just as a bit of a disclaimer, I'm not an expert in critical appraisal, and there's a good chance that this may generate more questions than answers. So hopefully you're not looking for certainty, but you've already made it this far, so. Okay, so what's the situation? It's not good. Obesity, diabetes, heart disease, and depression the rates are all increasing across the board in Canada and most Western countries. And, alongside that, the prescribing for those conditions is also increasing. We know, or at least I feel pretty comfortable saying, that there's good evidence that regular physical activity benefits at least 30 different chronic diseases. And if you want to see evidence for that, you're welcome to ask me later on. I have lots of a hard drive full of it. So despite this, we're not very physically active. In Canada, 4 out of 5 adults do not meet the current physical activity guidelines. And the story is similar in the United States and the UK. And in addition to all of this, there's not a lot of studies that directly compare exercise with drugs. So here's the first study that I wanted to look at. So this is a study that looks at the effects of exercise and pharmacological interventions on visceral adiposity. So just as a reminder, visceral adiposity is the fat that accumulates around the midsection, and it's really what's on the inside around the organs, and that causes the organs to dysfunction, and it's associated with metabolic disease, heart disease, early death, et cetera. So it is an outcome that we're interested in. It's measured in volume, so it usually requires some imaging modality. So it's probably not practical for most of us, but it is something that's useful in research. So this study looked at adults without any obesity-specific comorbidities. And the intervention was exercise or weight loss drugs, and the comparator was placebo. So they looked at 2 outcomes. The primary outcome was change in VAT, or visceral adipose tissue, and the secondary outcome was changes in weight, BMI, or subcutaneous adipose. And this was a systematic review and meta-analysis of randomized controlled trials greater than 6 months. So what did they find? So they managed to scrounge up 17 randomized controlled trials, 12 for exercise interventions and 6 for drug interventions. 1 trial looked at both. I just have the drugs listed here that were studied in these papers. And I have in the table there highlighted the results of interest, visceral adiposity. So by the way, these numbers are in standardized mean differences. So just if you're not familiar with that, that's a method of standardizing the measures when you have randomized controlled trials that are trying to measure the same outcome with different units. So you can standardize that and create one number. So just for reference, 0.2 SMD is considered a low effect. 0.5 is a moderate effect, and 0.8 or more is considered a large effect. So both exercise and drugs versus placebo did affect visceral adiposity. It looks like exercise was a moderate effect here, and drugs had a lower effect. You can also read the outcomes for weight, BMI, and subcutaneous adipose tissue, but change in weight was actually not significant between the 2. They reported on dropouts in this trial, this study, I should say. The 18% of the participants dropped out in the exercise group and 12% in the drug group. And they did not report on the adverse events. So in summary, we can say that reducing visceral adipose tissue is associated with decreased cardiovascular risk, and this is reviewed by the authors. and that's irrespective of weight loss. So I think that might be an important point if you're ever counseling patients, that looking at the scale is not the greatest measure of health in this case. However, exercise did lead to greater reductions in VAT and BMI than did drugs. Weight loss was probably similar in both groups, exercise and drugs, but exercise probably leading to more dropouts. And the authors sort of ponder at the end whether combining both would be even more effective than each on their own. Okay, so here's the second study I wanted to look at that looks at blood pressure, comparing exercise to drugs for blood pressure. So this study looked at adults with or without high blood pressure, but without any specific comorbidities. So the interventions were drugs or exercise, and comparators, usual care or other exercise interventions, placebo or other drugs. And the outcome was simply systolic blood pressure measured in millimeters of mercury. And this particular study was a network meta-analysis of RCTs greater than 4 weeks. So what they found in this trial, so here it looks as if in terms of RCTs, both they found similar numbers for the drugs, for the drug trials and the exercise trials. But if you look at the actual number of participants in those trials, there's about 3 times as many total participants in the drug trials. They also broke it down in terms of different types of exercise and different medications. So in the table of results there, if you considered all the participants here, there was really no significant difference in the mean change in systolic blood pressure. So both were about 8 or 9 millimeters of mercury. And if we just think about what Dr. Wright had said earlier, that's probably on par with what we would expect for drugs at least. However, if you just focused on hypertensive patients, you did start to see a bit of a difference, and exercise looks like it's becoming more effective now. So that was an interesting little subset of the study. This was a sensitivity analysis that basically showed that as you analyze patients with higher baseline blood pressure, the impact of exercise was increased. They didn't really make any clear comments on dropouts, but they did imply that there were higher number of losses in the drug or the exercise trials, and again, no adverse events were just not reported. I also included here just the network diagrams from this. So just if you're not familiar with these, so each point there represents a node, and the size of the node is proportional to the number of patients in the study. And if a node is connected to another node, that means there's been a direct comparison there. So you'll notice from these diagrams that there's no lines connecting exercise and drugs, so no direct comparisons there. And what they did find is that exercise, not as effective as drugs for the general population, but as you looked at hypertensive people, then there's really no discernible difference between the two. The other thing that the authors comment on is the heterogeneity in the exercise trials, and basically what that means is what these authors called exercise was kind of a hodgepodge of all kinds of different physical activities. We don't really know what they were in terms of what type of exercise, the dose of the exercise in terms of the intensity or the frequency, and et cetera. The other thing is that they do comment that healthier patients seem to be enrolled in the exercise trials. Okay, so this is the third paper I wanted to look at. This is exercise versus drugs for depression. And this looked at adults with non-severe depression, so as diagnosed by DSM criteria for mild or moderate severity of depression. And the interventions were exercise, antidepressants, or both, compared to control exercise or antidepressants. And the outcomes were first depression severity by any scale, and treatment acceptability, which was really just how well the patients or the participants were able to stick to the treatment that they were given. And this study was a systematic review and network meta-analysis and pairwise meta-analysis. So a pairwise meta-analysis is just when you have 2 meta-analyses that share a similar comparator, you can combine them and sort of create sort of a composite meta-analysis, but you can only do that with 2. And these were randomized controlled trials greater than 4 weeks. So what did these guys find? So 21 randomized controlled trials that comprised 25 different comparisons. So just note in this study, only 3 direct comparisons of drugs to medications. So in terms of results here, again, these results are reported in SMD, standardized mean difference. So it looks like for both exercise versus control and drugs versus control, both had an effect, and it was pretty similar. In terms of treatment acceptability, it actually looks like there were more dropouts, and this is a risk reduction. So there were more dropouts in the exercise group, or it was less acceptable than in the drug group. And just there, I did, there's also a standardized mean difference representing the indirect comparison between exercise and drugs, and that was 0.12, not significant, at least not statistically. So dropouts, again, a little bit more in the exercise group, and adverse events were reported in this study. The number of participants who had adverse events was 22% in the drug group and 9% in the exercise group. Okay, so again, a network diagram there, and if you look, this one does actually have a line joining the exercise and the antidepressant groups, but still very few direct comparisons overall. And exercise, however, for non-severe depression, looks to be about as effective as drugs. However, drugs probably cause more adverse events. Okay, last one, let's look at mortality. So exercise versus drugs. Adults, so the study group was adults with coronary disease, stroke, heart failure, or prediabetes. So the reason why they chose these 4 conditions is because those are the conditions for which there was enough data to actually do this project of comparing them. The interventions were exercise or drugs compared to exercise, drugs, or control, and the outcome was simply death. And this was a meta-epidemiological study, in other words, a pairwise meta-analysis and network meta-analysis similar to the previous one. So they managed to round up 16 meta-analyses, which comprised 302 randomized controlled trials overall. So just note, out of those 302, about 250 were drug trials, so the vast majority of them looking at drugs. So as you see in the results table here, I've only just given you the results for the 2 categories of disease that showed a difference. So for stroke, it looks like exercise had the edge over drugs there, reduced with an odds ratio of 0.09. If we look at heart failure, however, it's you see the opposite case. So drugs seem to be more effective than exercise in preventing early death. And the drugs that they looked at were diuretics for heart failure. For stroke, they looked at anticoagulants and antiplatelets. So that's why there's 2 numbers there. So as I said, there was really no difference between the coronary artery disease group and the prediabetes group. So exercise and drugs equally effective. Dropouts were not reported. And the authors only comment that for exercise, the evidence for adverse events is limited. And they did refer back to a few other studies, including some Cochrane reviews. So in summary for this one, so again, same story, very few direct comparisons of drugs to exercise. Starting to sound a little bit repetitive. There's quantitatively less evidence for exercise overall as well. So there's just less trials and there's less participants in those trials. Exercise, however, does seem to be about equivalent to drugs for preventing early death in coronary artery disease and prediabetes, probably less effective for heart failure and possibly more effective for stroke. And the harms poorly reported. So what are the conclusions, or what can we take away from this? So the good news is, from my perspective, as somebody recommending exercise to everybody, is that exercise seems to benefit these conditions in primary care, so hypertension, visceral adiposity, which is associated with lots of other bad things, bad chronic disease stuff, non-severe depression, and it delays mortality in stroke, prediabetes, and coronary artery disease. And the benefits seem to be similar to the medications that are used for these conditions, and there's few, if any, side effects. And if we sort of look at the heterogeneity issue, one way to look at that is to say, well, we don't really know exactly what exercise works, but it all seems to work. There's probably many ways to get this useful kind of exercise. So as I usually say to my patients, something is better than nothing. The bad, okay. The bad news is still chronic diseases are getting worse. Most of us are not physically active enough. And there's very little research that directly compares the effect of exercise to drugs. And one other thing that I've noticed just in my time looking at the evidence and in some of these particular papers is there's really not a priority in many influential expert groups For example, in the DSM-5, physical activity is noted as a treatment for depression, but only after the patient has been tried on antidepressants or cannot take antidepressants and it's failed. In Hypertension Canada guidelines, it's there, but it's downgraded to the grade D level of evidence. So that's sort of like the bottom of the pile. So you might see that in the fine print at the bottom of the page. So it's really de-emphasized, let's say. We don't know much about the existing evidence for the dose of exercise, what type of exercise is optimal or best. That's sort of the flip side of the heterogeneity issue. We don't know what factors promote adherence to exercise regimens, and that's something that I think is very interesting for us. And we don't really know what the harms of exercise are, but your patients will tell you. Okay, now the absurd. Okay, so I think like something for me that comes up when I think about this is something a little bit sort of maybe a bit silly about making this comparison, but I think it's, it's worthwhile. But there are clearly limits to using randomized controlled trials to evaluate the evidence for these kinds of complex interventions. And I think we sort of need to acknowledge that. So all of the studies were probably rated as poor quality evidence because you can't really blind an exercise trial, right? And also there's just paucity of evidence for exercise compared to drug stuff, and there's probably different reasons for that. But it's important to remember that lack of evidence does not equate evidence for lack. So that's one point. The other point I wanted to make is there's sort of a breadth-depth trade-off for randomized controlled trials. So it is a tool to focus very deeply on, it's great for a pharmacological intervention where you can sort of look at the molecular mechanism and try to trace that out and give you some rationale for why you're doing what you're doing. But it doesn't help us see that maybe one intervention may have possibly other effects that might you could think of their lateral effects or off-target effects. So that's something that you want to think about with physical activity. And I think that creates a bias in our practice. It tends to favor or prioritize, a more reductionistic approach to care. It favors high-tech, more expensive treatments, and it favors treating surrogate markers. On the other hand, it sort of devalues or it obscures the safety. If we don't ask these questions in trials, then we won't get the answers unless somebody goes back and looks, right? And it also devalues the patient's subjective experience, which I think, for longitudinal family practice folks or other people who are doing longitudinal care, we know that that matters. There's broader implications of these treatments in terms of the impact on the environment, the impact on the community, and then there's an existential impact, I would say, in terms of meaning and purpose that people get out of the treatment. So taking a pill with a glass of water means a lot different to us than investing time and energy and going out, getting active somewhere outside, right? And I think that makes a difference as well. And then it also steers us away from asking other questions that might be more relevant, like how do we get people to get more active, which I think is a really important one. So I think about a little bit of the parable of the police officer and the drunk. So the drunk, I don't know if anybody knows this, but the drunk I've got a picture of that, so maybe we'll just show the picture. But basically the idea is that we're looking where the light is for a key that we may not even need. There may not be a key to this problem of health. It might be just the matter of getting up and walking out of the light. And so a perfect RCT, does that even exist? Obviously, there's lots of issues for that, for these complex interventions, but even for pharmaceutical interventions, we know, as we've seen, there's lots of issues, and we need to look closely at with the evidence that we're presented with. And finally, a little bit of an issue for me, as my own personal pet peeve, is it possible that there's sort of a threshold beyond which more evidence just muddies the water and it sort of diverts our attention from more important questions? And I think the question that I have is, how do we use our limited medical and research resources wisely? So that's it. That's my idea of how randomized controlled trials, how helpful they are in looking at exercise. And so if there's anything that I hope you take away, it's that you talk to your patients about physical activity and a little bit more. And that's it. Happy to take some questions. So the question is about exercise versus dietary changes for weight loss. So I think there's pretty good established evidence that exercise is not a great way to lose weight. And that was actually sort of implied with the first study. So exercise, I actually tell my patients not to look at the scale if they're just sort of adding exercise into their lifestyle changes because they might not see much. It takes a whole heck of a lot of exercise to lose weight. So that would be well beyond the 150 minutes per week. That's in the guidelines. Patients may even gain weight if they're strength training and eating well, more muscle mass, more bone density, more blood volume, et cetera, et cetera. So I think those are some points to keep in mind. So I would agree. For losing weight strictly, probably diet has more of an effect than physical activity.
One other question from online is, what are your strategies for motivating patients? For example, an OA patient that says, I can't really exercise because I have so much knee pain.
So what are the strategies for motivating patients? Yeah, so that's a whole other talk. And it's an ongoing area of kind of like fascination and fun for me. But basically, I would say that I think there's a couple of simple things. There's certainly lots of tricks out there. Setting a SMART goal is really good. That's one thing I would say. Just make it very specific and make it very personalized to the person. So there is some evidence that just saying get your 150 minutes a week helps. But if you really wanted to go beyond that, then you really want to look at what the patient is capable of, start out with what they're capable of, and then set some very small goals. So that might just be a 5 or a 10-minute walk 3 or 4 times a week. But you really want to get that specific specificity of the goal down. So that's one thing. Another thing I would say is just to educate patients, like for osteoarthritis in particular, if exercise is done well, it actually helps. It can reduce pain. There's probably neurological and immunological reasons for that. We know that, and we were just talking last night at dinner about how there's sort of a sweet spot of physical activity where inflammation actually is at a low point. If you get no exercise, inflammation is high, and if you get tons of exercise, then it gets high. But somewhere in the middle is a sweet spot where inflammation is low. So, yeah.
One last question for online, and then we'll move to the room. So they're talking about the Mayo Clinic meta-analysis that looked at drugs versus exercise and said that in 2019, there are probably very few people on GLP-1 drugs.
Yes.
And so do you think the impact of those drugs would be bigger, more meaningful? Do you have any comments on what modern practice?
Yeah. Thanks for seeing that. Yeah, so there's some pretty interesting choices for drugs there, and atorvastatin, I had no idea was considered a weight loss drug, but whatever. So yeah, I think there would definitely be a difference, but again, I'd be very curious to know, I'd be curious to look at the visceral adiposity as an outcome specifically. I don't know much about GLP-1s and visceral adiposity versus weight, for example, so that's one thing. I think this also just sort of makes me think of this last slide here a little bit too, is like, sure, you might see some very specific improvements in weight and A1C and things like that, but you're not going to get the kinds of improvements in, other mood, psychological benefits, blood pressure benefits, all these other things that you can get with physical activity, mortality reduction, and the lack of side effects. So yeah, I think it would be an interesting thing to see, but I wouldn't expect it to change my opinion in any way whatsoever, to be honest.
Just a comment on the GLP-1 aspect, as Josh was saying with respect to other effects on the body, not just looking at the weight, the GLP-1 is going to reduce muscle mass, and it could lead to a legacy prescription situation where you try to get rid of the drug later, and their weight balloons possibly even higher than it was. So the exercise will be a more robust change.
Right, and so this issue of like potential sarcopenia with GLP-1 agonists, I think is something really interesting. It seems that people seem to lose muscle mass. And I don't know if that's because their protein intake may go down and they become less physically active because they don't see a motivational reason to do that. There's probably different reasons. But I think I see many patients on these medications and I really even push harder for them, and I try to get them to increase their protein intake and do resistance training because I warn them there's a good chance they might lose muscle mass. Yeah, so the loss of muscle mass in itself is a risk factor for chronic disease and loss of independence for people as they age, so it's important.
Yeah, I wonder if there's another factor with exercise, and that's overcoming some of the isolation. I'm thinking more of older adults. And if you're lifting weights in your basement by yourself, that's one thing. Mm-hmm. But if you're going to the gym and there's other people there and maybe the trainer's helping you use the machines, maybe go out for coffee afterwards, the whole idea of exercise is you maybe actually meeting with other people.
Yeah.
Whereas if you're taking a drug, you're swallowing it at home with a glass of water.
Yeah.
So
I agree with
yeah,
that.
that could be
absolutely.
part of it.
And this is again sort of speaks to this idea that there may be other sort of benefits that we may have not seen or thought of because of what we're sort of focused on with the evidence. But I think that being physically active can potentially be a way for people to build their social relationships and enhance community if people are walking together. And these walking groups could be really fantastic things for people to join, because also, this idea that people are more motivated in groups too. Yeah, 100%. I agree.
Is there any evidence that looks at parasympathetic type exercise compared to sympathetic?
Could you give me an example maybe?
Parasympathetic is more walking, doing something that's relaxing, drives the parasympathetic nervous system, and then weight training would be the opposite, drives the sympathetic, the stress response in our body.
Yeah, so the way my brain kind of works when I think about exercise is I think about intensity. So that's a question for me about the intensity of the exercise. So I think about, so for low intensity exercise like Tai Chi or yoga, there are documented benefits, and they may be slightly different than those that you get with strength and cardiovascular. Like, for example, they're probably better for balance. They might be better suited to people with chronic musculoskeletal conditions. In terms of the benefit that you have to get, you probably have to do more volume of that in a week to get the same benefit that you do with higher intensity exercise. But it's still, like, again, my philosophy with everybody is just something is better than nothing. So, if you're anything really, honestly, like standing up out of your chair every hour if you're working at a desk is helpful. So, yeah.